Yeah, you can't see me. I think my camera needs a driver update, and that's an issue, but luckily, not that attractive anyway. And you can see my PowerPoint. So let's get into that, get down to business. So we're talking about anxiety. Again, we talked about whether it's an external or internal threat, and the fact that anxiety is going to depend on what you think it is and your perception or the individual's perception. And they're going to have a somatic component. So the autonomic nervous system, the sympathetic nervous system, is going to activate. And of course, we did discuss what that does. It's going to raise your heart rate, your blood pressure, could give you some heart palpitations. You could have nausea, diarrhea, trouble sleeping, decreased sex drive, irritability, dizziness, sweating, and chest pain. So yeah, all that fun stuff you get before clinical or before you go to whoa, what's going on here? Or before you go to your test, right? So you have different forms of anxiety, mild to severe. What is mild anxiety? Because you know your tests love to ask these questions. Mild anxiety is increased alertness, broad field of perception, and of course, it's going to enhance learning and performance. Moderate, this is where you start tuning out stimuli. I think I get this at work because, alarm fatigue. I blame it on having anxiety because I get so in tune with my work because I'm so anxious about it all being a certain way that I really do limit my perceptual field. I narrow down and I really am like super focused and I tune out all the stimuli except those bed alarms. Definitely don't tune that out, right? Those get me every time. But you really super focus and you tend to tune out on a lot of those things because your anxiety is high. And that tends to happen to a lot of us at work. I know I'm not the only one. Um, Unfortunately, it does decrease our attention span as well, which is kind of a good thing when you're on the floor because you do need to be able to swamp from one thing to the other very quickly. But in tune with that, it can decrease our problem solving ability. And this is really important with patients because you will get patients that come in, they're anxious, and you're trying to like talk them down. Maybe even a friend is having an issue. And you're like, gosh, why can't they see this is an easy fix, right? It's because they're so anxious. And because they're so anxious, it doesn't make sense to them, they're getting confused and they're not able to see this really clear uh, solving of the problem. So that does happen with moderate anxiety. And then, of course, it can get so severe that you really aren't thinking much at all. You're just kind of acting. That behavior is directed towards just trying to relieve the discomfort that you're in or that you're going through. You have a narrow or distorted perception or cognition, flight of ideas, physical symptoms as well. And then lastly, we have panic. And panic is where you're absolutely disorganized, irrational, overwhelmed, out of control. This person could become violent, hysterical, or immobilized. And this is that, of course, SNS system really fully taking into effect. And it is the deer in headlights. Like you just do not know what to do. You cannot comprehend what to do. And that's a scary place to be because you may do something that's irrational that works against you in some way. So that could be an issue. We do have levels of anxiety listed in your text. And of course, you always want to assess them based on the objective and subjective data that the patient is experiencing. Look at what coping mechanisms your patients tried before. We were talking a little bit about the last week of class and how we're having interventions for anxiety throughout the week. And of course, y'all gave me some great ideas. I've got another one from Professor Mullins, somebody suggested. Great idea. We'll present that as well. But yeah, meditation, pet therapy, art therapy, music therapy, exercise. It's going to be different. Journaling, talk therapy, I mean, prayer. The list goes on and on. It's different for each person. So you really have to figure out what works for you. And again, once you guys get me in clinical or in professional nursing, we're going to talk a little bit about developing a care plan for us. And hopefully that will get you through your first year, because you have to recognize what things work for you now before you get into this situation. And yes, nursing school is lots of anxiety with it, but on the job, it is going to get a little more intense. So if you're prepared for it, if you have these interventions in state, you're going to be much better off than the person that isn't prepared, isn't aware of their anxiety, and just kind of like playing it by ear and seeing, day to day how they can handle things. And it sounds great, but unfortunately that doesn't work well. Come on, puppies. So same thing with our clients. We will try to detect whether or not they have a strategy in place, what things they've been doing in the past, their coping mechanisms, things that they've used to reduce their anxiety. And again, if they are in severe anxiety or a panic, those things may not work. And I'll give you an example. Severe panic and anxiety. I have panic attacks. I haven't had one in a long time, maybe about every 10 years. It's really not that bad, but I do have Xanax available just in case. And I don't think I had one, knock on wood, for quite some time. And, my father passed recently, and I was doing great through most of this. And then all of a sudden, the day of the funeral, I couldn't find my sunglasses, and I started crying, and I was sweating, and my heart was racing, and I couldn't breathe. I just couldn't get my breath. That's a very good example of a panic attack. And it was irrational. I had stressors going on, but they weren't directly attributed to what I was physically going through, right? And nobody could calm me down at that time. I knew I had to catch my breath. I knew I had to isolate myself for a moment. And I knew I had to take my Xanax. I was at that point, right? So that's just a example of how panic is different from severe anxiety. Because with severe anxiety, I think we've all had that as well. I can remember, being on a plane and hitting some, what do they call it? Rough air, turbulence, rough air. Yeah. And thinking, oh my Lord, this plane's going to crash. I wonder if this pilot knows what he's doing. And, people around me are nervous. So that made me nervous. And I could talk myself down from that still, So that's kind of the difference between severe anxiety and a full-fledged panic attack. Panic, you just can't really work with a person. You need to really get them into a safe place. Where severe anxiety, yes, you can still kind of gently help that person down with their stress and so forth. So those are kind of the differences. Anxiety disorders, lots of us have anxiety, and those of us that have it really bad probably already know that it is going to interfere with functioning and self-care. It's hard to take care of yourself when you are extremely anxious, because you are already feeling at loss, and therefore your self-care starts to slip. And as your self-care starts to slip a little bit, you start becoming depressed. So that's another reason I have my graduating seniors write these stress care plans, because I want them to make sure that they can deal with stress and anxiety on the job and prevent what's called nursing burnout. Anxiety, Most are chronic, but it can be in response to acute situations as well. And of course, challenging to treat, very challenging to treat. So, anxiety disorders, the mental health, National Institute of Mental Health, of course, these are a bit older. I'm sure this is much, much higher now. But it always takes a while for results like this to get published. So you have the the National Institute of Mental Health saying in 2009, about 18% of the population over 17 is going to report anxiety. And like I said, I'm sure that's much higher post COVID. The first episode tends to be around 20. And it usually, again, is going to involve some or reoccurrence or co-occurrence with depression and or substance abuse. And of course, the easiest one is benzodiazepines. You get a prescription and then you start relying on them, and then all of a sudden you're taking one daily. Then, of course, they don't really work well anymore because you have that rebound anxiety that tends to occur with the chronic use of benzodiazepines. So then people turn to alcohol or cannabis, more so alcohol. It's more acceptable, and they're trying to get some relief from their anxiety. And then, of course, that leads into depression, which leads into more alcohol use. And you have that cycle that you get trapped in, as we know about with our substance abuse content. So, common to have one or more of these with anxiety, especially in the future if we don't address and interact with our anxiety. So, understanding of anxiety, you have internal advantages, right? Gained efforts from the relief of physical anxiety. So, what happens? You get physical symptoms. A lot of us will have back pain, stomach pain, nausea, just chronic pain. I know when I get very anxious or very depressed, I feel it throughout my entire body. I'm definitely somatic, definitely somatic. And I think a lot of people are like that. So, to help our patients navigate through their pain, we have to look at their mental well being as well, because a lot of times anxiety is coming into play there. And for some people, that's going to also involve obsessions. I like the lady cleaning because I think for us females, especially, we will take out a lot of our anxiety by trying to reach this level of cleanliness, perfection that may or may not really exist realistically. But that is a way to attempt to gain control over our environment. I don't know if men are like that. I can't speak to that, but I definitely know I've seen a lot of females try to fulfill that role as keeping their environment very clean, and it becomes an obsession. It could also be a compulsion. Compulsion is where you just feel you have to do this. You have to do this. You don't know why. And you are trying to relieve anxiety through that. And then, of course, some people, they can get so anxious that they have severe worrying and fears. The can't drive, I put that in there just from my own experience. Again, hopefully this will help you remember these, concepts. But after being in a car accident, I remember having very bad anxiety for at least a month with driving, because of course, when you're in a situation that's unpredictable, where you don't have control, that's going to create anxiety, and then that's going to create irrational fears. So lots of our patients are going through that as well, where they may have a fear related to a past experience now causing them extreme anxiety. Worry and isolation definitely occur as well. And then we have what's called secondary gain. So this is basically the attention or benefit obtained from letting others have by having anxiety related disorder. So this can be more important than relieving the anxiety. It decreases the motivation to get well, and others take care of the individual, so it can complicate treatment. So basically, this is, having basically being invested in that sick role there, that can cause some issues with certain patients. So, our axis one of anxiety disorders, this just comes from our DSM-5 book. So, when we're diagnosing our patients, we have different axes of anxiety. And axis number one is basically generalized anxiety disorder. This could include panic disorder with agoraphobia or without agoraphobia. What is that? That is the fear to leave your home. Some people get that so bad they don't want to leave their home. They want to just stay because they just can't deal with their anxiety or panic outside of the home in the public. Obsessive compulsive disorder, we did talk about that today under cluster C. But again, that's that compulsiveness to do a task over and over or past really perfection to alleviate anxiety. Phobias, definitely being afraid of certain things like driving, public, so forth. That will fall under there. And then somatoform, again, that's just feeling pain that is released because of that anxiety. Um, Acute and post-traumatic stress disorder and dissociative disorders are not covered in this lecture. So I just wanted to mention that. But basically, what is post-traumatic stress disorder? That is going to be related to some type of event that's occurred in the patient's life where they basically are experiencing continual anxiety or stress, and it's often suppressed into their mind, and they may or may not recognize that is what's truly causing their anxiety. So etiology and theories of anxiety, you've got biological theories, transmitter dysregulation, altered numbers of benzodiazepine receptors. So again, maybe you're truly just born more anxious than not, and that's where that theory comes into play. You also have the genetic theory, like we have in most of our mental health disorders, that is relaying to possibly having it run in your family, maybe mom or dad or whoever experienced a lot of anxiety. I'm actually reading a good book called It Didn't Begin With You, which even talks about it being on a cellular level, and that a lot of what moms are feeling and even dads that are feeling during prenatal care is internalized in that child. So that's another part of that genetic theory that we're now exploring. And we know that things matter when you are pregnant and the baby is starting to internalize uh, different emotions, even way um, beyond, the birthing cycle. So like even before that. So inherited traits for shyness have also shown to be predominant in those with anxiety disorders. So it's kind of curious as well. Psychoanalytic and psychodynamic. What do we have here? We've got the result of conflict between instincts and values, and then also defense mechanisms that are used to manage discomfort that's resulting from anxiety. Things like repression, displacement, and conversion. And of course, some of those we talked about earlier in the term when we were looking into therapeutic communications. And then we have the interpersonal theory. The interpersonal theory basically states that anxiety is caused by a threat to the self esteem, security, or self control of an individual. So that definitely could be a causative factor of the patient's anxiety as well. So again, lots of different theories in mental health for lots of different reasons behind each of these disorders. So no matter which cluster or disorder we're talking about, we always have different methods of thought And of course, with each type of thought comes different types of treatment. So that's why those are just important to recognize, because it justifies the treatment that we're giving the patient. So let's look at generalized anxiety disorder, also known as GAD. It's a very common type of anxiety. Got cognitive and physical symptoms involved here. This is going to be chronic and excessive worry that's greater than 6 months, and it's habitual. It can't be controlled, it can't be talked down or out of. And this is to the point where it's causing the patient impairment in their life. So maybe they're not able to go to school, or they're not able to actively look for a job because they're constantly shooting themselves down before they've ever tried. The goal for GAD is basically to assist the client to develop adapting and coping responses, assess the level of anxiety, try to figure out if it's moderate to severe, and work in reducing those levels of anxiety. Of course, this is going to depend on your patient, and you're going to have to work with your patient to find what works best for them. So it's not a simple thing to do. It does take time. Identify and describe feelings. The best way we do that at the practitioner level is really to have the patient journal their thoughts and emotions. I don't know if you ever kept a diary, maybe when you were in middle school or something like that, but definitely this becomes really beneficial when we're looking at therapy and causation factors for the patient. And then again, that assists the identifying factors as well. And again, we can help journal. These are just little faces. Sometimes with younger patients, we will give them a journal, and they'll actually color in one of these faces, and they'll write about their day. Um, so that kind of helps them. Milo management for generalized anxiety disorder, you want a very calm environment. So again, you're going to see this on any floor of the hospital. It could be obviously in the emergency room, and it's kind of hard to decrease activity there. But maybe you can get them to the floor quicker than not. We can dim lights. We can turn off TVs. You can silence your pump alarm. You can silence any alarm you need to in that room and program it just to ring to your phone. So that's always an option too. You can also turn the light off on the pump. I don't know if you know that, but there's a switch, a little button on the back you can push, or a key code that you put in. A lot of times it's like 911 or something, where you can put that into the pump, and it actually looks like the pump's off, but the pump's still running. So you can decrease stimuli in your patient's room. I know it's hard in a hospital, but it is possible. Make sure you have relaxation activities, even if it's something as deep breathing, meditation. Um, we can work in groups as well. And again, we're going to be doing that the last week of classes. So please, please, please join us. I'm actually going to see if we can't. Well, it's 11 to 1, so you guys will be out of class. So it'll be your final after your final. But maybe you'll feel like coming down on Wednesday. So we'll definitely have to make sure we lead up Wednesday's event if you can, if you feel like staying around. Panic disorder, again, reoccurring sudden intense feelings of apprehension, terror, impending doom. It is really a loss of control on the patient's part or on the client's part, and they almost feel like they're going crazy. They really, and they don't have control, and depending on how much control they're used to having is going to be how this affects them. And if you're somebody who's used to having a lot of control, you can slip into this pretty easily when you lose that control. So that's what a panic disorder really is. And of course, that can involve somatic symptoms. I can definitely speak to that. I thought I was having a heart attack when I was having my panic. I knew it was a panic attack, but definitely it mimics the signs and symptoms you would see in a patient with an MI. We always rule out an MI first because that's what nursing does. But you will see increased blood pressure, increased pulse, decreased O2 sat. However, you run your EKG and you probably just have some tachycardia there. You're not seeing any ST elevation or depression, which means, yeah, your patient is not actually having an MI, but they sure probably feel like they are. It can also be recurring, so we do want to get these patients treatment if needed. Oh, where's my thing? I thought I had more slides. So there we go. There we go. It may or may not be situational. If situational, avoid those places or situations if possible. And then those panic attacks do tend to peak over about 10 minutes. Panic disorders and anxiety disorder also may involve that agoraphobia, which is basically just that fear of leaving your home or going into public places. And that can be very debilitating for some folks. So, the etiology of panic disorder, psychologically, we have life stressors, separation, disruption of attachment, childhood tends to kind of lead to that. Theory, basically. And then biologically, hereditarily, it might be seen in families. You might have interaction of the cognitive with the SNS system, endocrine responses, again. That could be very relative to the patient and their demeanor, their familial situations as well. What do you need to do with your patient? Communication, similar to panic level and anxiety. Stay with them. Make sure they're safe. Calm environment. Decrease stimulation. Assess for suicidal ideation. Use touch carefully because, again, if this is a extreme panic attack, that might not be received well. And then PRN medications are going to be Xanax and Ativan or benzodiazepines. Definitely, this is what they were made for right here. Improvement is going to help. Client teaching. Remember, a lot of times they feel like they're crazy. They're just going out of their mind. They need some reassurance. Recognize and address the triggers with these patients and recognize the symptoms. And again, meds can help, but they're not going to be solve all for the patient either. Again, relaxation exercises, yoga, stretching, soft music. Moving is big. Walking, jogging, basketball. That's why exercise is so good for you because it actually brings your body up to match this SNS. And of course, with exercise, it brings the SNS back down to the parasympathetic nervous system because your body was not meant to live in the SNS state, in the fight or flight response. It was meant to live, or to be a majority of the time, in the parasympathetic nervous system, which is at rest and digest. So, exercise actually just matches your activity and then brings it all down. And that's why that's so important to mental well being. Outpatient, we can work on cognitive restriction. So basically, helping them troubleshoot their anxiety and behavioral mechanisms and triggers and so forth. And then obsessive compulsive disorder, we talked about this today again. That's that reoccurring, persistent thought or idea. Here we have somebody locking all their doors, making sure their doors are locked over and over and over. There's the cleaner, the person that wants to clean all of the time, the hand washer, but they're basically intrusive and senseless at this point. It's not like this is a healthy thing. It's repetitive for the point of being repetitive and definitely just kind of like an obsession. And the patient could be doing this to prevent some discomfort or to neutralize their anxiety. So that's kind of why they are doing these things. They often have depression and low self-esteem and lots of anxiety especially if they don't um, do whatever the compulsion is. So I know there was a question at one point. That was a good question. It was a patient had been diagnosed with either anxiety or OCD, and they're in the waiting room and they're organizing the magazines over and over. what is the best intervention? And the intervention was to allow the patient to do that. Because again, the theory is if you stop the patient from doing this compulsion, it's just going to make them more anxious. So I thought that was a pretty good example to kind of remember. This person needs to control things. So that's why they're doing these obsessive compulsive dysfunctions, really. They need to control. But again, it's very time consuming. This is interfering with their life. They tend to have some magical thinking behind it. They believe that thinking equals doing sometimes, and it interferes with their relationships. So it is very paralyzing to the life of this patient. So what do? We assist to, meet their basic needs first and foremost. Allow them time to do these rituals. It's really hard because if you suppress them, again, they're going to get more anxious. Explain expectations. Identify feelings to connect the behaviors. Introduce new activities slowly with this patient. Reinforce and recognize relaxation, stress management, recreation, social skills, assertiveness, and of course, our wonderful cognitive based therapies. And this will include what we call thought stopping. Thought stopping is kind of going through this in your mind and having a different thought and not the physical response. So that's kind of what that is. And here's our little critical CRCJ for the day. It is a 42-year-old married secretary who's been coming to the health clinic for years. They have some minor physical complaints, so the somatic pieces. And they're telling the nurse that they worry about their family and home so much they can't sleep at night. She can't specifically name anything that's a significant problem with the family or home. They deny marital problems, except my husband says I worry too much. Increasingly, she fears losing her job due to the problems of concentrating and constantly calling on the family from her cell phone. So, what do you think her nursing diagnosis would be? Um, so if you kind of put that into perspective, yeah, she's got some anxiety, uh, ineffective coping is what she's going through. So that's kind of what we would start helping her with, and we would walk through that anxiety pathway that we just spoke about. So just putting that into reality. Phobias, according to the DSM, it is marked in specific and it's an excessive and unreasonable, basically, fear cued by the presence or anticipation of an object. The person knows it's unreasonable, and the situation or object is avoided at all costs. Anybody have a phobia? Anybody afraid of spiders? Arachnophobia, right? So yeah, it seems like everybody's got something if you look hard enough. And agoraphobia without panic disorder, that's the fear of just being in a public place. Lots of people have that. Social phobias is another big one. That's just a fear of being humiliated in public. Again, we have a lot of that. I think even more so because anybody can record you at any point. So I'm sure that's a big piece of it. No, you were just outside. You were just outside. No, sorry. And then specific phobias, that's your spiders and planes and elevators or whatever type phobias people have. And again, you kind of know that this is an irrational thing, but you just can't quite get over it, and you're not quite sure why you're afraid of these things either. So that's another issue. Sorry. So treatment, we use outpatient treatment most of the time, and behavioral therapy could be that systemic desensitization. So example, like if you were afraid of flying, you would go to a support group. Maybe you go visit an airport. Maybe you would get on a plane that wasn't moving and you would sit on that plane and then you would eventually work up to flying. So again, that's desensitization. We talked about that week 1. And then the opposite, if you remember, was flooding. That would be like, oh, you're afraid of flying? Well, we're going to take 10 flights today. That's what flooding is. So that would be the opposite of that. And that's not really that therapeutic. Of course, the military in certain camps like that will use that theory. And the nurse-client relationship interventions are going to be really similar to generalized anxiety disorder. Somatoform disorders. This is anxiety relieved by developing physical symptoms, and there's no known cure or no known cause for these things. So again, people just say, everything hurts and I don't know why. Sometimes we say they're hypochondriacs. They're coming in, they're saying they're sick. They might be taking their anxiety and actually converting it, conversion disorder, into a physical manifestation because they're not understanding how to interpret this anxiety, or we'll classify them as having a pain disorder. The characteristics of this, there's some type of psychological conflict and the client's not in control of their symptoms and complaints. They see general practitioners a lot of the times. They haven't been properly diagnosed through the mental health tract because it hasn't even been addressed appropriately that this is a mental health disorder. And that does take some time, right? Not to anybody's fault. It just takes time. Because, of course, we're always looking for the physical ailments first. We have to rule those out anyway. We have a repression of feelings and conflicts, unacceptable impulses, denial of psychological problems, and, of course, the individuals can be dependent and needy. They're very invested in the sick role, as we say, meaning that they have a primary and secondary gain, often because they're getting attention. And that kind of pulls back into the fact that it helps relieve their anxiety because somebody's there, more or less. Somatization disorders. This is recurring complaints for several years. The complaints usually change over time. Usually it starts before 30 years old, but again, it does take a long time to really say that this is what's going on because the person's going to see a lot of physicians. The physicians are going to refer to one another because they're not finding anything. So it's something that really does go under or undiagnosed for quite some time. And then they'll come to us finally as mental health patients. And then, of course, I think they get a lot of stigma for that because people don't understand somatization disorder. This can also involve unnecessary surgical procedures, definitely impairs interpersonal relations. It might set them up for chronic emotional abuse. They might be unable to verbalize anger. So really, these patients have a world of issues because of this. And then one of the last items we're going to discuss just briefly is pain disorder. And that this does exist. And of course, I think what happens is internal med will bounce these folks around quite a bit as well. And they are complaining of severe pain in one or more areas, significant distress and impairment. The location or complaint doesn't change. They tend to doctor shop. And I think it's just because they really do feel something's wrong, just like your other somatic patient. They're just not able to get an answer. And if you're not able to get an answer, you're going to continue to look for it. So sometimes they get a lot of negative stigma for being quote unquote doctor shoppers, but really what they are is they're looking for an answer, and eventually they will come to mental health to be treated. And then of course we have to go through the whole pain medication thing with them and making sure that they are treated appropriately and so forth. So the secondary gain, so the primary gain could be, pain medication. The secondary gain that they're getting, of course, being invested in that sick role allows them to avoid things that they maybe don't enjoy doing. or that's causing them displeasure, such as going to work. And when there's a psychological or physiological discomfort, the amount of pain tends to be out of proportion. So we definitely see that. Hypochondria, and I think in truth, too, along with that, I really do think that these patients do feel this. I think this is very real to them. I know sometimes you'll hear nurses and providers really talk negatively about them, drug seeking and so forth, but these patients really are feeling something and they just can't explain why. So that's how strong the mind, I think, has really taken over the body, which we know that can happen. Hypochondriacs, this is that person that worries they have a severe illness despite no medical evidence, right? Like patho. You remember being in pathophysiology and every disease that came up, you weren't sure if you had that or not. Lots of people go through that. It is a misinterpretation of your body's symptoms, and you need reassurance from family or friends. And what was that movie that had the animals in it? And there was a giraffe that was a hypochondriac. The giraffe always thought it was sick or injured. I forget. But anyway, good example of that. And then conversion disorder. This is another suggestion of a neurological condition where you have a deficit or alteration in voluntary motor or sensory functions. It can be somebody who is perceived as paralyzed, blind, or has seizures. And this also tends to be exemplified through conflict stressors and um, so forth. So I don't think, I know somebody asked me, who is that? Gypsy Rose, I think is her name. You know, did she have conversion disorder? Maybe mom did. But I'm not quite sure on her. I don't know enough about her to say yes or no on that one. The nurse client relationship and management of stress and somatoform disorders. Yeah, she definitely had Manchurian proxy issues for sure. Mom did on Gypsy Rose, but I just don't know about the full fledged conversion disorder. Uh, okay, anyway, a nurse client relationship and management of somatoform disorders. Always rule out the physical, show acceptance and empathy. Don't challenge. They're going to pick up on that. It's going to make it worse, not better. Encourage identification, appropriate expression of emotions, and teach those adaptation skills. So our CRCJ is a 20-year-old Army private was brought in to the medical unit with persistent chest pain and weakness. He was scheduled to deploy to Afghanistan. Oh, after days of diagnostic testing, no physical cause has been found. The treating cardiologist and neurologist suspect somatization or disorder. The client has a trusting relationship with the nurse. Which statement is helpful to the nurse? Why or why not? And I noticed you were scheduled to go overseas before your illness. Do you think there's any connection between that and your symptoms? Would that be helpful? Why or why not? Yeah, probably. The doctors seem that there's nothing wrong with you. How do you feel about that? Interesting response. Tell me what your strong points are that will help you to get through this. Oh, that sounds like a good answer. Very good answer. Medications for anxiety, benzodiazepines, CNS depressants. These compete for the GABA receptors. We talked about these before. This is just a review, hopefully. They actually decrease the response of the excitatory neurons. You can develop a tolerance and dependence for these. And again, a lot of folks that keep using these tend to get more anxious. And then they really fly off the handle when their meds are not given. So that's why we don't like to use them anymore unless we have to. And then we use them only for really panic attacks and so forth. But that's for short term. Stopping abruptly when you're on them for too long can cause seizures. Shorter acting benzos can be used for PRN. Clonazepam and lorazepam are the best ones for that. We tend to give out Buspar or Buspirone nowadays for our first line of defense. This also binds to serotonin and dopamine disorders. SSRIs also work really well. So this one doesn't have any side effects as far as CNS depression go or abuse, but you can have some paradoxical effects. Again, increased anxiety is a big one. Benzos have that as well. So, especially with older people, you give an older person Ativan to settle down, and then all of a sudden they're running down the hall naked. That's what a paradoxical effect is. Um, Buspirone, the only problem with it is it does have to be taken daily and really doesn't start kicking in for 3 to 6 weeks. And it can cause extrapyramidal side effects as well. So we do have to monitor that Ames scale for those effects. Antihistamines can be used. That's Benadryl. Benadryl is a big one. Vistaril as well, or hydroxine. And these are really sedating. It says no addiction potential, but I disagree because I actually know of a patient right now that is taking an obscene amount of Benadryl. If you've ever chased down that rabbit hole of what do they call it, the Hat Man or whatever, it's a group of people that are so addicted to Benadryl, they're taking these obscene amounts and they start hallucinating. So I'm going to argue that there probably is a little bit of potential for abuse that we're now just picking up on. But at the time, these fell under non-abuse abused medications. Um, Useful in long-term panic with or without agoraphobia, obsessional thinking, and then of course SSRIs are really our first line of defense now with anxiety, especially Lexapro. We're getting Stellapram, getting lots of really good results with that, but we can still use fluoxetine, that's Prozac, sertraline, citalopram, and so forth. So any of these can be very useful in reducing anxiety, and tricyclists as well. But the tricyclic issues with overdosing, so they're not going to be really popular out there. Um, Propranolol, Inderal, and clonidine also can be used to reduce panic, and gabapentin. Guidelines for these anxiolytic agents: watch for sedation, potentiates falls and accidents, so use carefully. Be very careful in the elderly because, again, their renal and liver is not what it used to be, so they can't process these meds very well. And then you have them overdosing or paradoxical side effects happening. Never combine them with CNS depressants or alcohol because, again, they could be overly sedating. Paradoxical side effects are common with the benzos, especially buspirone and even some antidepressants. So again, you really have to assess and reevaluate your patient. Don't stop abruptly. And that is it. Hopefully, and show here. Hopefully, this records nice. If you guys have any further issues, I will see you during class. Yay, yay. 13th and 14th, I gotta go to Orlando for Union. If I take the next Oh my goodness, please tell me that recorded. Wednesday, Thursday, Friday, Saturday, Sunday, you had to wait all. Hopefully this recorded. Let me see how this goes because this is the first time I've There it is. Okay, stop recording. All right, have a great night, guys.